Hello, everyone. My name is Ravinderjeet Singh. I'm a stroke neurologist at Health Sciences North, Sudbury. And so I'll be presenting briefly about the intravenous thrombolysis and acute stroke. The intent of this talk is to summarize some of the evidence and how we select patients for acute stroke therapy. And at the outset, I would like to thank Sue Worley, who is our Regional and Education Coordinator, for keeping me on track for this presentation. So before I begin, I just want to highlight that this is not a comprehensive talk on stroke by any means. Again, this is an overview as to what's new in terms of the stroke therapy and where do we stand regionally in terms of our service, as there has been a lot of changes in the guidelines and recommendation, mainly driven by recent trials. And also I will take this opportunity to congratulate all the team members here at HSN. We are now a full stroke service. We became 24/7 EVT service starting November the 15th. We have done over 30 cases so far when we initially started in February 2020. And we have done almost, I believe, around 6 cases since we became a 24/7 service. And of course, the volume is growing, and it's a very exciting time for the region as we are able to offer this treatment now locally here at HSN, and with the regional partners, we are now a complete stroke service. So thank you, everyone who has been part of this this team and this journey when we started years ago. All right, so we'll get on track with the presentation. So I have nothing really relevant to disclose as far as this presentation is concerned. And again, the intent here is threefold. One, I want to just talk about how the treatment window has changed over time. We want to rationalize why we do reperfusion therapy in acute stroke and what is the evidence behind this. And of course, we want to see what kind of patient really benefit from this patient and how we select these patients. So it's a very brief talk. And again, just to give a perspective, we know that a stroke is one of the most common neurological and vascular disorder, and it carries high mortality and morbidity and a huge economic cost to the healthcare and to our communities. Most of the stroke, as we know, are ischemic strokes, which constitute about 85% of all strokes, and about a third of these ischemic strokes can have a large clots, what we call as large vessel occlusion. And both this groups, although they are similar in terms of the initial approach, they do differ how we treat them and how we handle the large clots, as I will discuss in a minute. And so, of course, if we know that most of the strokes are ischemic, mostly are caused by occlusion of the artery, one of the intracranial artery, then it makes sense to recanalize this artery to reverse some of the deficits. Now, this may or may not happen in every individual, as we know that with every passing minute, part of the brain is getting damaged in the territory supplied by that occluded artery. So when we get later into the time window, we have very little brain to save because most of the brain, which is supplied by that ischemic territory, is already has died, and what we define as a core of that infarct. And but in other patients, there might still be a lot of tissue around that core, which is still salvageable. And again, this depends on the time from the onset. So it's very important that the treatment window should always be carefully figured out. And one of the way we try to determine, as I'll talk later, is to know when did these stroke symptoms start. And in some cases, it's unclear because they were asleep or there was no witness onset. In these cases, the time they were seen well is considered to be the possible time of onset, although it may or not be a right assumption, but this is how we usually take the time from onset. And so once we know that a time from onset falls within certain window, we basically have two options to offer here. Either we can use a TPA or alteplase or intravenous thrombolysis, that different ways of describing the same thing, where the underlying theme is that we give intravenous medication to dissolve the clot. And depending upon the agent, we can call it as TPA or Actylyze, which is more of a brand name, although I do not endorse to this brand as such. And the second option is if the clot is big, which is shown on the large on the vascular imaging, then we can go after this clot and try to pull the clot out. So either we have option of busting the clot or retrieving the clot, and that depends on basically important variable being the presence or absence of a large clot, which we can see on the CT angiogram or the MR angiograms. So the time window, as we see that it rapidly falls, and the benefit of any therapy rapidly goes down as we go away from the time of onset or lasting well. And if you see, this is a systematic review of all the trials which used alteplase, and it was published in Lancet by Emberson et al. And what it shows is that it's probably around close to 5-hour window that we start to lose overall efficacy. And this is based on all ischemic stroke patients. It is not based on presence or absence of the large vessel occlusion or small vessel occlusion. It's all ischemic stroke patients who were offered alteplase. And but most of the guidelines, they recommend up to 4.5 hours, although there has been now newer trials which suggest that this window could be extended to up to 9 hours in a highly select group of patients, but of course utilizing some of the additional variables, mainly the imaging-based patient selection. That has not become a standard of care, and extended window alteplase or thrombolysis is done in some centers and is done more on a case-by-case basis. Until it becomes guidelines, we will still stick with the 4.5 hours time window. So if the onset is within the last 4.5 hours, this patient is potentially eligible for TPA. Of course, will require additional selection criteria, which I will talk in a moment. And the second cohort is the patient who have ischemic stroke, but now have a demonstrable large vessel occlusion. So there's a big clot in one of the proximal artery. And these are the patients who benefit from endovascular thrombectomy. And you can see again, this is a systematic review of the first of the 5 trials, which were published in 2015. And what it shows is that the benefit stays slightly over 7 hours. And although subsequently there were 2 more trials which were published, which demonstrated that the effect of the EVT could also be seen in patient at extended time window if they are properly chosen. And again, the later time window is heavily based on some of the imaging criteria more than the clinical criteria. Of course, sometimes we do combine the two, but I would say once the clinical criteria is met, then we need additional imaging criteria to really fulfill the delayed window selection piece. And talking some of the evidence, and again, I don't want to bring too much of a historical trials here, but I think one of the key trial was 1995 NINS trial, and everybody talks about it. And even prior to the NINS trial, there were several in vitro models, animal stroke models, and angiographic human studies, which actually tested that the alteplase does work. And but the first large multi-center RCT to investigate intravenous alteplase in humans using a strict patient selection criteria, standard operating procedures and outcome assessment at 3 months was done in NINS trial. And prior to that, and during this time, there were several other trials done which used different thrombolytic agents, different doses, different routes for administering a drug. It used various patient selection criteria using combination of imaging and clinical criteria. There was various approaches used to monitor and control the peri-procedural blood pressure, and even medical management in individual patient, like starting the antithrombotic was quite variable. The outcome assessment was quite variable in terms of when it was captured after their stroke, and also the definition used. So it becomes really difficult. And what this is one of the major problem with a lot of these dilemma which prevails in some of the scientific fraternity as to whether the thrombolytic really work. And we need to understand that there has been a lot of heterogeneity among these studies, so it's very difficult to draw conclusions. And so NINS was the first one which kind of overcome many of these drawbacks of the previous or concurrent studies, and therefore was a very robust study to show. Now, of course, the benefits were not huge. They were moderate benefit, but it was enough to really benefit a large patient numbers when we consider the scale of the stroke overall. And unfortunately, there was no other therapy available back then. And what it showed is that the functional outcomes improved in these patients. And this is from the original NINS trial. And again, I just want to highlight a few points that between the TPA-treated arm, which is here, to compare to the placebo arm, what you can see here is there's percentage improvement is in favor of the TPA-treated patients. So there is a neurological severity reduction, and this get captured in the GCS, in the modified ranking scale, and the Barthel index. So if you see whatever type of measure you try to do, everything is in the right direction. And the effect, which the outcome, which we currently measure using modified ranking scale, and you can see here in this group is about 20% difference between the active, the treated group versus the placebo arm. And you can see this is the shift analysis where or Grana bars, and which you can see that the TPA treated patient definitely had the shift in the right direction. Mortality was quite similar. And of course, as anticipated, the hemorrhage rates were higher in the TPA treated patients. And most of these hemorrhage, when they occur in many patients, they are fatal hemorrhages. But fortunately, the numbers were not too high. So overall, if we combine the benefit, the absolute benefit to the absolute risk, it was clearly in favor of the alteplase. And it works across the type of stroke. So whether it's cardioembolic stroke, large vessel occlusion, or small vessel disease, in all three subset, there was a benefit. And following the NINS trials, there has been further attempts to expand the patient population using a longer time windows, and also using imaging to select patient in patient who had unclear onset. And this was done in Extend trial, ECOS-4 trial, and Epithet trial. And also Wake Up trial was the very important trial, which used the MR-based paradigm to select patient at a later time window. But essentially what these studies were trying to identify is a patient population which can be benefited at a longer time window. And there were also attempts to improve the efficacy or the safety of the alteplase, either by using lower dose, as was studied in Enchanter trial, and also using transcranial Doppler to help lyse the clot. When the TPA was given, the transcranial Doppler would further facilitate the recanalization. And again, they showed marginal benefit. And also people tried different agents to see if that confers a better efficacy to safety profile. And so far, what I could say is that tenecteplase seems to be having a very promising future. And of course, there are several trials ongoing, including Tempo 2 trial, and the results of which is awaited. And hopefully, we'll have more data in the year 2. And at the same time, people have also tried to use not the intravenous route, but the intra-arterial route to see if alteplase works better. And as shown here, there were several trials done. And the results were encouraging, but the effect size was not huge. So and with the endovascular mechanical thrombectomy coming into the picture, it kind of fell out of favor. And so this is the Lancet meta-analysis, which combined all the trials done using alteplase, and it clearly shows that the patient, it's a time-dependent benefit. So as we move away from the onset, the benefit kind of starts dropping. And the benefit is present in both younger and older patients, and it really doesn't depend on the initial NIH, although the safety seems to be better in the lower NIH stroke scale. The most important question is, when patient is presenting with a stroke, what subgroup of patient really benefit and where not to use IVT. And so these are the three patient criteria. So we have basically the patient-related variables, we have stroke-related variables, and we have agent or the thrombolytic agent related variables. So those are the three key components which kind of form the cornerstone of patient selection. And here I have kind of broke them down into the components. So in the stroke part, so when we talk about what kind of stroke this patient had, of course, it needs to be acute. So that means 4.5 hours. It needs to be ischemic stroke, and we need to prove it by doing non-contrast CT. And it has to be stroke and not a stroke mimic. So that means if a patient has hypoglycemia or a patient with migraine-related hemiplegia, those patients need to be excluded. And so that's the minimum criteria before we can start even thinking about giving TPA. And the second part is the patient criteria, which is disabling deficit, which we can assess, as I will show in a minute, using different severity scores. And we need a good baseline functional status, and we need to select patients who have low bleeding risk. And again, I'll show you some of the criteria, what defines as low bleeding risk. And in terms of the agent, it's basically a match. So if patient fulfills the stroke criteria, has a patient selection criteria, then you can basically administer the agent, and it is intravenous alteplase as of today, and it's 0.9 milligrams per kilo with the 10-90 split. That means that you give 10% as bolus and 90% as infusion over an hour. And where you should not be using IVT, it's again where you don't think this is acute, so it's a non-acute, so either it's a resolved deficit or established ischemia, or it is non-ischemic, so that means you see hemorrhage on the scan, and it's non-stroke. So if it is a mimic presentation, of course, you don't want to give TPA. And in case of patient, if the deficits are very mild and non-disabling, you would probably be cautious before using TPA. If somebody has a very poor baseline functional status, probably it's not really worthwhile to put them at a risk of having bleeding, where the benefit is really marginal if somebody has a very poor baseline functional status. This could be a patient who are already have severe dementia in nursing home, or patients who are in palliative care, or patients who already have end of life care, and high bleeding risk patients. And again, I'll show you what are those patients where how you need to screen for high bleeding risk. And of course, you don't want to give TPA in this cohort. And again, this is to highlight what I just discussed. And acute means it has to be within 4.5 hours from the last seen well or from the witnessed onset. The ischemic stroke should be documented where basically it's a lack of hemorrhage and no big established infarct. And it has to be a stroke, which we use basically clinical criteria. And as far as the patient selection, it has to be a disabling deficit, which we can capture most of the time on NIH. Sometimes NIH may not capture the full spectrum, especially the distal hand issues, where we might have to use some clinical judgment, but mostly NIH is a decent tool to define what is disabling versus non-disabling. And we need to have a good pre-morbid functional status. So again, for that, you can use the modified ranking score, which uses scale of between 0 and 6, 6 being, of course, that the worst outcome was a death. And so we are talking mostly between 0 and 5, so where patients have either 0 is completely independent and does not have any symptoms, to various other levels. And 3 is usually a cutoff where a patient is not ambulatory. So above 3 is non-ambulatory patient, and 3 or below is patient who is ambulating independently. And of course, you need to use historical, clinical, imaging, and lab criteria to define low bleeding risk. And we talked about the agent. And where you don't want to use this is basically contraindication. And historical criteria is any previous history of brain hemorrhage. So any intracranial hemorrhage becomes an absolute contraindication. Of course, there is also a lot of discussion as to not all intracranial hemorrhage have the same potential for rebleeding. So if you're planning to consider TPA in this patient, it will be very select group of patient and would qualify for off-label use. And in patient who had a recent stroke or a serious head or spinal trauma in the preceding 3 months, you should be very, very cautious, although it's not an absolute contraindication, but it is a relative contraindication. If they had a recent major surgery in the last 14 days, again, it becomes a relative risk. So that means you, in some certain circumstances, you might be able to use it, but you might have to have a discussion with the surgeon as to what the risk entails. But that becomes a relative contraindication, not absolute contraindication. And the same is true for arterial puncture at a non-compressible site in the last 7 days, again, becomes a relative contraindication. And as far as the clinical part is concerned, again, if there's a high clinical suspicion of subarachnoid hemorrhage, you don't want to give TPA. Of course, with the non-consular head CT, you can easily exclude it. But if you still have some suspicion, then you might have to do lumbar puncture before you could thrombolyze these patients. Now, we need to be very cautious because even doing lumbar puncture becomes risky in the setting of if you're planning to give TPA. But I would say mostly and safely you can exclude SCH on the non-contrast head CT. And of course, doing endovascular imaging adds to that. And stroke symptoms other than a stroke. So that means any stroke mimic you don't want to really, so that becomes a relative contraindication. Of course, the presence of seizure at the onset is not an absolute contraindication because sometimes the seizure could be a manifestation of a new stroke. But if you have sufficient ground to say that there's no underlying stroke and it's a seizure only, which is causing post-rectal paresis, then it's a contraindication. You don't want to give the medication to these patients. And if it is difficult to control blood pressure or a patient taking blood thinners. So if you see the whole idea in the historical and clinical criteria is to identify any of the hemorrhage or trauma to the brain, hemorrhage or trauma to the spinal canal, and any hemorrhage or major trauma in the major trunk systems, and or if somebody is on blood thinners. And as far as the CT, it's quite obvious. If somebody has already well established large infarct, you don't want to give TPA. And also patients who have an extreme of blood sugar levels, because that could be the explanation for their deficit. You don't want to thrombolyze. And but of course, same as I said for seizures, if you have sufficient ground that it's the stroke, which is the problem here, and not the dysglycemia, then you can certainly thrombolyze these patients. But of course, you need to correct the parameter before you can go ahead. And if somebody has coagulopathy, either manifested in the INR or platelet count, of course, you need to be very cautious in these settings. So again, the idea is to identify some of the historical measures, variables, clinical variables, imaging and lab findings to identify a patient who is at higher risk of bleeding into their brain or elsewhere. And so just a quick review, which will be when do you consider stroke therapy or TPA therapy? And it's a patient who is coming acutely, has ischemic stroke, and does not have mimic features. And what are the contraindications? Ask for trauma history, any major surgery or procedures recently, any recent hemorrhage, any big tissue infarction recently, whether it could be MI or stroke, any blood thinners on board, and high blood pressure. And we need to assess before we can embark on giving TPA. We need to know that these patients had a decent baseline functional status. And what do you need to document before giving TPA? At least you need minimum of blood pressure. You need NIH stroke scale. And here you can see it's an 11-point scale with a score between 0 and 42, 42 being the worst score. And people distinguish mild, moderate, severe based on different cutoffs. And one of the common cutoffs which is used is under 5, which is mild, 5 to 15 is moderate, over 15 is severe. But of course, this varies in different studies. And some of the studies have defined over 21 as severe. So, but this is probably the easiest way of trichotomizing these patients in under 5, 5 to 15, and over 15. And disability with either you can get the sense from lack of severe dementia and good mobility, or you can use a more formal way of documenting by using modified ranking scale. The idea is to get patients who has a decent functional baseline, so that when you're capturing their follow-up, you are comparing individuals who had a decent outcome. And if somebody is already modified ranking 3 or more to begin with, or 4 or 5, you're not going to make a huge impact in terms of their prognosis overall. And so when do we do? So that was about intravenous thrombolysis. So again, just to summarize, the key thing should be an acute ischemic stroke, which has disabling deficit and lack of high-risk bleeding features. The endovascular thrombectomy, and again, I will be talking only patient selection, because as far as the contraindication is concerned, there are very little. And largely they are based on some of the angioanatomy, how the vessels are, how difficult it would be, and how risky it would be. But in most settings, the easiest is to first understand what's the selection. Most of the time, there are no big contraindication as far as the EVT is concerned, because we can use this procedure in patients who are high risk for bleeding. If somebody had recent trauma, can be considered, as long as we have a decent anatomy to reach to the clot. And so there are very few settings where the EVT is contraindicated, and I would say it's better to just understand the indication here rather than the contraindication. And the indication is, the first is, of course, you are going with the devices to pull the clot out. So you need something which is large to retrieve. So you need a large vessel occlusion. And how we define it, if you see this is circular villus, so the proximal parts are called large vessel occlusion. So if it is an internal carotid artery, or it is the proximal part of the middle cerebral artery, those are the classical large vessel occlusion, although there is emerging literature that you can use it for even medium vessel occlusions with good success. But for now, we are using large vessel occlusion as a criteria. And you don't want these patients to have a large stroke already. So if there's an established infarct, and the size of the infarct can be captured by different variables. So you have softwares which can calculate it for you. The easiest is to use aspect scoring, which gives points to different areas of the NCA territory. And if the score is over 5, these patients likely have a smaller infarct, so therefore a good candidate. And again, similar to TPA, we need somebody who was previously independent and has a decent life expectancy to be able to pull through the first few months. Otherwise, again, it becomes it's not really a good therapy, and rather it's probably would add to the complication. And the treatment is available for both early and late presenters. So the early presenter are within first 6 hours, and the late presenter up to 24 hours. So that means the EVT has a much longer treatment window, up to 24 hours, and can be offered as such to these individuals. But again, as you see, the selection is based on not only the clinical piece, but also a lot of the imaging criteria, which includes the vascular imaging to show that there is a large vessel occlusion and a sizable area of the brain which you can salvage with this procedure. And that's pretty much it. And as far as the evidence, we all know that, and I just alluded before that there were 5 back-to-back trials, and after that there has been subsequent lot of real-world registry-based studies. They all uniformly show that it works, and EVT has one of the least number needed to treat. I would say the lowest number, I shouldn't say the least, that lowest number needed to treat, and it could be as low as you have to treat just 2.5, like almost 3 patients to get 1 patient to have a benefit. and some of the other windows, it could be as large as 5. So it varies. So the effect size is huge. So it is very robust treatment, and one of the most robust treatment found in medicine. So it's worth trying this for our patients who are eligible for this treatment. And just to summarize, the treatment window for stroke is expanding, and patient selection has been rapidly changing and improving. Despite imaging-based case patient selection in the recent trial, the time-based approach is still valid. And so we have to know the first thing which we have to know is when did the symptoms start? That should be our first question when we are dealing with a patient who is either he has stroke or is suspected to have a stroke. And knowledge of how they were doing before their stroke is very, very important before we can really embark on any of the acute therapy. And finally, for TPA, it's very crucial to calculate the bleeding risk based on some of the variables which I showed. And while for EVT, the contraindication are not those many, but it relies heavily on the vascular imaging for patient selection. And so that was the quick presentation. And again, you are welcome to contact us. And I have provided here my email and our new network email in case you have any questions related to this presentation. Again, we look forward to continue to grow. And our stroke program has expanded, and I'm really, again, very excited that our service has become truly regional with the full spectrum of stroke service here. It's really a time to celebrate, and thank you for joining today.